In this capture, we're going to do a review of the anatomy, physiology, and assessment of the neurological system. So looking at the neurosystem, you want to keep in mind that it controls all motor, all sensory, autonomic, cognitive, and behavioral activities. It literally is the control center of the body. And we have the CNS, or central nervous system, which is comprised of the brain and the spinal cord, and the peripheral nervous system, which is the cranial and spinal nerves, the autonomic and somatic systems. All of this then breaks down into the basic functional unit, the neuron. And each neuron has a cell body and an axon with the nodes of Ranvier that are coated with a myelin sheath. It's really important that you understand this because as we move further in this unit, we're going to be talking about disease processes that affect different parts of the neuron and that affect neurotransmitters. Speaking of neurotransmitters, each neuron produces specific neurotransmitters that are released into the synapse, and they can either enhance or inhibit an impulse. Okay? There are enzymes that will destroy the neurotransmitters because you don't want to keep them there forever, so we need to have a way of kind of resetting it. Or the enzyme can reabsorb it for future use. Okay, but it's all about a balance. As I mentioned before, many of our neurological disorders are caused by an imbalance in neurotransmitters. We'll talk about the imbalance with acetylcholine for myasthenia gravis. We don't necessarily talk about depression in this course, but serotonin and norepinephrine play a huge role in the treatment and incidence of depression. And we'll look at dopamine and how it can cause, or lack thereof rather, can cause Parkinson's disease. So just a basic review of brain structure and function. Okay, this is not Anatomy and Physiology 1. You do not need to know down to that level, but you do need to have a basic understanding, especially as we start talking about disease processes such as stroke and how that's going to affect your patient. So if you remember the frontal lobe, that's what controls your voluntary movement, your speech, your behavior, your judgment, reasoning, abstract thought, concentration. It's really all the stuff that makes a person who they are. Okay. The temporal lobe contains the auditory center and the language center. So if you have somebody whose temporal lobe has been affected, they're going to have issues with auditory perception and communication. The parietal lobe controls sensation, and the occipital lobe is responsible for vision. So just kind of keep in mind those basic things. Down in the hypothalamus and the thalamic area, that's where your autonomic nervous system is controlled. The cerebellum is responsible for balance and equilibrium, and your brainstem that contains the midbrain and the pons, that controls the involuntary cardiovascular and respiratory function. Looking at circulation, it's kind of important to understand some basics about cerebral circulation. So you have the image on the screen there, okay? Everything pretty much starts with the carotid arteries. That's what is delivering almost all of their blood flow up to your brain. So if you have an issue with the carotid artery in your neck, where there's a blockage or there's, some plaque buildup, that's going to affect circulation to the brain. Those carotid arteries come up and branch into the anterior and middle cerebral arteries and then into the vertebral arteries. Those vertebral arteries then branch into two posterior cerebral arteries. And all of this is joined together by the circle of Willis. So it's important to kind of understand the basic circulatory structure because if there's a blockage or there's a bleed, there's a problem in an area, the rest of the circulation has to kind of pick up the slack. And sometimes it can't. There are certain areas that are fed by a specific vessel. The autonomic nervous system regulates activities to maintain and restore internal homeostasis. So when you have that flight or flight response and your heart rate goes up and everything's all stimulated, you can't stay like that forever. Okay, so you have the counterbalance that brings you back down. Okay, the sympathetic and the parasympathetic. Okay, and that mostly uses your norepinephrine. We are not going to really talk about spinal cord injuries or anything like that as part of this unit in this course, but this should provide a little bit of a foundation as you move on to your future med-surg courses. So let's talk about assessment, and it starts with the health history. As you're talking to the patient about the symptoms or conditions they may have, you really want to note if they're having pain, and specifically headaches or any sort of neurological pain. Are they experiencing seizures? If so, how often? What precipitates them? What type of seizure? Are they having weakness? Are they having numbness, tingling? Are they experiencing tremors? Any dizziness or vertigo? Got vertigo on there again. Are they having any type of visual changes or changes in their speech? Okay, whether it's the tone of their speech, the appropriateness of their speech, the clarity. Are they perceiving abnormal sensations? Okay, do they feel like there's bugs crawling on them or something's underneath their skin? Have they had loss of consciousness? If so, what was the precipitating factor for how long? You want to look at past medical and surgical history. You also want to look at family history. Some of the disease processes we'll talk about have a genetic link, so that might be good information to have. And then, of course, if there's any type of psychosocial issues, psychiatric issues, and really, if they're having any type of neurological impairment, how is this affecting their daily life? What is the impact on their lifestyle? What is their impact on their abilities? How has it limited them? For the physical exam, you want to look at mental status. And we'll start with level of consciousness. Probably at this point, most of the patients you've been exposed to have either been alert or lethargic. Okay, but if you work your way down to the level of consciousness scale, we have stuporous, we have obtunded, and then all the way down to comatose. Okay, your comatose patients, they do not respond even to any type of painful stimuli. For orientation, do they know who they are? Do they know where they are? Do they know, relative to the time? Do they know the month? Do they know the year? And are they oriented to their situation? Do they kind of know what's going on? Sometimes you really need to talk to a patient to know, are they truly oriented or are we seeing some confusion? Because some of your patients can kind of fake it till they make it. And they kind of know what questions you're going to ask them. So sometimes you really got to engage them and get them to talk about, so tell me what brought you to the hospital. And, when you think about orientation to time, are their thoughts making sense? Are they constructing an appropriate timeline with the events? So that's pretty important. GCS refers to Glasgow Coma Scale, and that looks at 3 components. It looks at eye opening, it looks at best verbal response and best motor response, and that kind of ties into that posturing. So part of your required reading and required preparation for this unit is to also look over your foundational content for neuroassessment and take a look at the ATI skills module specific to the neurological assessment. For cognitive and intellectual function, you want to assess both short-term and long-term memory. You want to note their attention span. Are they able to do some abstract thinking or, some math calculation? What is their overall mood? Do they have insight into their situation? What's their judgment? Are they making good decisions? Are they making poor decisions? Part of the physical exam is also reflexes. We won't necessarily focus a whole lot on that as part of this unit. But as you continue on in your med-surg courses and as you get into OB and start talking about pregnancy-induced hypertension and treating somebody with magnesium sulfate, reflexes are going to become a bigger deal. Language ability. You want to note their speech quality, their quantity. Are they one-word answers? Are they talking a lot? Is it like a forced answer? What's the volume? What's the clarity? Is it making sense? Is it meaningful? Is it appropriate? You also want to note if your patient is experiencing any type of aphasia. And the two big types of aphasia are expressive and receptive. So expressive aphasia, I can understand what you're telling me. I just can't formulate the words to be able to respond appropriately. Okay? I have trouble speaking. I know what I want to say. I just can't say it. Receptive aphasia is the opposite. You're speaking to me and it's gibberish. I have no idea what you are saying. I cannot interpret it and it's not making sense to me. You can have patients that have a mixed expressive and receptive aphasia, but you need to know the difference and be able to respond and interact with them accordingly. You also want to note any dysarthria or difficulty speaking. Like I said, it might be difficulty moving the muscles and enunciating the words. It might be difficulty finding the right word, kind of word searching. You see that a lot with older adults, and particularly with dementia, with Alzheimer's, where they're searching for words for what they want to say. You also want to evaluate motor function. So coordination. Can they close their eyes and, do the, finger to the nose test? Can they do the, heel down the shin? What's their gait? Do they have a steady or unsteady gait? How's their balance? Do they look like they're going to fall? Evaluating muscle strength. Remember that 0 to 5 scale. If you're in clinical and you're not using that 0 to 5 scale to assess and document your patient's muscle strength, you're missing out on something. That's pretty important. Know the difference between hemiplegia and hemiparesis. Okay? You're going to have a quiz on terminology. You need to know these things. You also want to note muscle tone. Is that muscle flaccid? Is it rigid? You might see rigidity a lot with your Parkinson's disease patients. Are they experiencing muscle spasticity? From a sensory perspective, you want to evaluate pain sensation. Can they identify sharp and dull? And you want to do that, extremities. You want to do that facial. Can they identify and perceive temperatures? Is something cold? Is something hot? How about light touch? Vibration using a tuning fork? 2-point discrimination, stereognosis, and graphesthesia, those are higher level tests that you'll see done as part of a very intense focused neurological assessment. And they're covered in the ATI skills module. So pay attention to some of those things that we don't necessarily do on every patient or even every neuro patient, but they're part of a full focused neuro assessment. Cranial nerves. It would behoove you to know about cranial nerve testing. Just saying. So looking at cranial nerve number 1, your olfactory nerve, the way you test that is for a patient to identify a scent. They close their eyes, be able to identify a scent. Optic nerve number 2, you can do this by confrontation. So you want to position yourself directly opposite of the client, have them close one eye, and you're checking their peripheral vision. When can they see your fingers, bringing them forward? You can also check the optic nerve using visual acuity with the Snellen chart. Again, you need to test the eyes individually. 3, 4, and 6 can be tested together, so that's pretty cool. And you actually do this as part of your typical assessment. Cardinal fields of gaze. Have the client follow your finger as you move it through the different cardinal fields of gaze. Remember, the eyes should move in unison together, and it should be a nice smooth movement. You shouldn't have that nystagmus. You also check for pupil response. Each pupil should have a primary response to light and a consensual response to light. Okay? Also checking for accommodation. For cranial nerve number 5, the trigeminal nerve, this is where your patient can identify light touch up by the eye, the maxillary, and the mandibular areas. So have them close their eyes. I probably wouldn't do the pin prick on a basic patient, but light touch is fine. Have them clench their teeth so you can palpate those muscles. The corneal reflex also checks cranial nerve number 5. However, take a look at that in the HI skills module and understand that we never, ever, 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 ever assess the corneal reflex in a patient who's conscious, okay? Please do not go to clinical and chart that you checked your patient's corneal reflex if you're on med-surg. Number 7, the facial nerve. You can have the client raise their eyebrows, close their eyes tightly, purse their lips, smile, frown. You're looking for that facial movement. You can also assess this with taste discrimination. Can they identify salty substance versus a sugar substance? Typo should be cranial nerve number 8, the acoustic nerve. This is where you can have your patient close their eyes and you can say a soft sound, you can whisper something into their ear, and they can tell you what you said. Number 9, number 10, glossopharyngeal and vagus. You're assessing the gag reflex, and you want to assess symmetry during swallowing. 11, the spinal accessory nerve. You can do this by having the client shrug their shoulders and turn their head side to side, both against resistance, to see how they do. And cranial nerve number 12, the hypoglossal. Have your client stick their tongue out, okay? It should be midline. They should be able to move their tongue from side to side against resistance. Obviously, you want to have gloves on and a gauze pad to check this. Now, as we get older, everything kind of slows down a little bit. Things don't quite work as well as they did when we were younger. So there are some expected age-related changes that you want to be familiar with. It is very, very important that you determine what their previous mental status was. So that gives you a basis for comparison. So family members can be very helpful with this. You know, just saying, you know, are they usually this confused? Are they usually this? You know, they'll be able to give you some insight as to that. It is not uncommon as we get older to experience some short-term memory decline, slower reflexes and motor responses, that delayed reaction time, okay? They may have difficulty hearing high-pitched sounds, so you want to keep that in mind as you're interacting with them to make sure you're using a lower tone of voice and not necessarily talking up here because they're not going to be able to hear you. They may experience some changes in their vision acuity. We call that presbyopia, old age eye. They may lose or lack some sense of smell. They may not perceive pain as easily as before and temperature. So kind of think about that from a safety perspective. Their fine motor skills, they might have a little bit more difficulty moving and slower movements with their fingers. As they get older, when patients get infection, they're at higher risk to experience delirium and severe confusion. So that is something that you really want to be aware of. And they also have a greater risk of depression. Part of that is the adaptation to these changes and having been independent and now maybe needing some assistance that kind of contributes to that too. But also the imbalance in neurotransmitters. And finally, just a couple key points on the assessment, the diagnostic testing piece. X-rays are X-rays, not really a whole lot to say about that. Cerebral angiography actually goes up similar to a cardiac cath where we're going up the vessels but now into the brain circulation. It often uses IV dye, IV contrast. So keep in mind all the stuff we had talked about that before, allergies, renal function, metformin. CT, MRI scans, again, can be done with or without contrast. MRI can be done with or without some of the different contrasts. So an MRI, metal, magnet, you just want to kind of be cautious on that. PET scan or a SPECT scan, that is actually a test that gives us much more finer detail than even an MRI, and they can do whole body PET scans. You typically see that used for evaluation of malignant conditions and metastasis. Lumbar puncture, puncturing in at the base of the spine and getting a sample of cerebral spinal fluid. EMG to look at muscle function and nerve conduction. EEG to look at electrical activity in the brain and cerebral blood flow. Those are often used. EEG is used with seizures and stuff like that too, but the EEG and cerebral blood flow are often used when evaluating brain function in somebody who may have sustained a head injury. And then, of course, carotid ultrasound, and that's more to assess the patency or potential blockage of the carotid arteries, mainly as a evaluation of a risk factor for stroke.